Thank you very much. Let me see if I can figure out the technology here. So we're shared, is that right? Okay, and there's my slides.
I think I have to start the share.
Okay, great. Okay, let's get started. So great to be here. Thank you everyone for joining in person, and for those of you online, it's really an honor to have an opportunity to speak to you today. So I'm going to be talking about seizures and lots of work from our group at the Neonatal Seizure Registry. Okay, but first, a lot of people ask me, my last name is Glass, which is like not that common a name, but there's lots of famous people named Glass. So people ask me, are you related to Ira Glass? Unfortunately, I'm not related to Ira Glass. Other people say, are you related to Philip Glass? Also not related to Philip Glass. But I am related to this guy, Dr. Lenny Glass, who's a neonatologist here at SUNY Downstate. Who unfortunately is no longer with us, but I don't know if anyone, I know we know at least one person in the crowd remembers Dr. Lenny Glass. It's an honor to be back to a place where family worked. So today we're going to talk about the causes and consequences of seizures in neonates. We're going to review the evidence for anti-seizure medication discontinuation after resolution of acute provoked neonatal seizures. We're going to talk about risk factors for infantile spasms after neonatal seizures, and we're going to learn about parent well-being for neonates with seizures. But first, let's look at a case just to orient ourselves of who we're talking about here. So this is a 12-hour male. He was initially doing well after birth, but was brought to the NICU for these focal clonic movements that were concerning for seizures. So the left-sided seizures were confirmed on EEG, and the EEG background was normal between seizures. He was treated with phenobarb, first 20, then 10 milligrams per kilogram, and the seizure stopped within 6 hours. And as some of you may have suspected, his MRI confirmed a left middle cerebral artery territory stroke. So I'll start just by talking about why I love to study seizures in newborns. And the first is that they're actually quite common. So if you look at the seizure incidence rate per 100,000, this is over the lifespan up to 80 years. Right here at the beginning, neonates actually have the highest risk of seizures, and that's about 1 to 4 per 1,000 live births. Seizures also often reflect serious underlying conditions like brain injury. Here's 4 of the most common causes of seizures in neonates: HIE, stroke, hemorrhage, infection. And together, 70% of seizures in neonates are provoked by an acute brain injury. Seizures are also often associated with adverse outcomes. These are data from UCSF. Of a cohort of 125 children, and about a quarter of them died. And then of survivors, 21% had cerebral palsy, 13% with low cognitive scores, 9% with epilepsy. And you can see in the middle here, a high number of children with multiple disabilities. Neonatal seizures also increase the risk of epilepsy. These are data from Kaiser Permanente of Northern California. Children with perinatal stroke. And what you can see is those children that presented with seizures from their perinatal stroke, here in the green and the hatched line, have 3 times the risk of developing later epilepsy, so unprovoked recurrent seizures. And that risk lasts for as long as we're able to measure it throughout childhood. But it turns out seizures are really difficult to treat and difficult to study. There's a handful of seizure treatment trials. People might be familiar with the Painter, phenobarb versus fosphenytoin. There was a Profeno trial, which was a duration of treatment study that ended up failing, unable to enroll sufficient patients. There was a couple small bumetanide trials, and then this recent Neolev trial. And then back when we started our work about 10 years ago, there was really like a handful of very small studies, but many of them didn't have EEG for diagnosis. Many of them were single center. That's all changed now. But back when we started, we really wanted to change the field by saying, EEG is really important for diagnosis. And why is that? Well, see, babies often have subclinical seizures. So unless you do an EEG, you won't know that they're having a seizure. And also babies have lots of funny movements that, it's hard to tell at the bedside. Is this a seizure? Isn't it a seizure? And again, about 10 years ago, the American Clinical Neurophysiology Society came out with these guidelines for continuous EEG monitoring. And so a group of us decided we wanted to take advantage of that and study seizures in newborns. And so this is our group of sites. And the unique thing about us was that we all follow these American Clinical Neurophysiology Society guidelines. And I don't think that's so unique anymore. But 10 years ago when we started, we were some of the first centers to really follow those guidelines. Another unique part of our study is that we have a parent stakeholder input for our study. So from ideas to design to analysis to dissemination, we have a group of parents, one from each study site, and also members of these organizations that are parent organizations. Here's just an outline of some of the work that we've done, and I'll be talking about the first two iterations. So initially a consecutive cohort of all comers. Then we enrolled prospectively and followed those kids for 2 years. And now we're working on 3 to 8 year follow-up, biomarkers, and genetic testing. So this is one of our first studies. We wanted to understand how long should we be treating babies with acute symptomatic seizures. So like the baby that I showed you with the stroke, once the seizures have finished, those acute seizures, how long do we continue the medicine for that baby? And there's kind of 2 main approaches. The first is to maintain the children on medication, and that is to wean the medication, usually phenobarbital in the babies, until about 3 to 6 months when they come back to follow-up clinic. And this is a historical approach. Uh-oh. There we go, coming back. So this is a historical approach, and it was developed really before we had good imaging to know what was causing the seizures, before we had good EEG to know if the seizures had even happened at all or when they had stopped. But people are concerned because phenobarbital is not a great drug to be giving babies for long periods of time. So if we can minimize that, that would be good. In our study, that first cohort of consecutive children that we enrolled, about 3/4 were maintained on their seizure medications at hospital discharge. The other approach is to discontinue the anti-seizure medication. So once those acute provoked seizures stop, to stop the medications. And that had been shown to be safe in small studies. But this trial that I mentioned, the Profino study, failed to enroll because of low enrollment. Families just didn't want that uncertainty of a placebo versus an active medication. And that was about 1/4 of the children in our study. But interestingly, the best predictor of treatment duration was actually the study center. So where you were born was most highly associated with whether you stayed on medicine or came off the medicine. And that range across the sites was 4% to 91%. And I showed you those centers. They're all fairly equivalent center, CHOP, UCSF, Boston Children's. They all should have similar types of patients that they're seeing, but these clinical practices are so very, very different. So we had this hypothesis that it wouldn't be harmful to stop the medicine early. And this came from some other studies. There were some small studies that showed a low recurrence of seizures and epilepsy despite short duration of treatment. But the limitations were that there were small studies, they're single center, and they were non-randomized. Now, we already knew that the randomized trial had failed, so we couldn't go back to doing that, but we did what we felt was really the next best thing, which is a comparative effectiveness study. So we enrolled children at all 9 of our sites across the US. And these are all sites with a level 4 NICU, level 4 pediatric epilepsy center. And as I mentioned, all following the ACNS guidelines for neonatal EEG monitoring. So we were pretty sure that we had babies that actually had seizures. We included any children with seizure onset less than 44 weeks, so as a neonate, and any acute provoked cause. So mostly HIE, but also strokes, hemorrhages, and other acute causes of seizures. We excluded anyone with a transient cause, so hyponatremia or hypocalcemia, anyone who had clinical events, those babies that have something that you think might be a seizure, but you're not sure, excluded those. We also eliminated anyone who had an early onset epilepsy. So kids with genetic epilepsies or brain malformations, those kids have to stay on medicine long-term. So we didn't include those. And then also children that didn't survive the neonatal admission. Our primary predictor was whether the anti-seizure medications were discontinued before the child went home from the seizure stay, or whether they were maintained at the time of discharge. Our primary outcome was this telephone questionnaire called the ILAE, looking at mobility, communication, cognition, and self-care. And our secondary outcome was epilepsy. Now, this is important. Our analysis was by propensity score, and this is a tool that we use to reduce bias due to confounding. So what does that mean? So you can imagine overall, the kids that were a little sicker are probably more likely to go home on medicine because the doctors think, oh, well, you have the highest risk of seizures, so we're going to send you home on medicine. So what propensity scoring does, it's a statistical matching technique. It uses these observational, so not randomized, but observational data to try to estimate a treatment effect, but accounting for the covariates that predict treatment. And it's a tool that we use to improve causal inference. So if we remember in an observational study, you can't always tell cause effect, but this helps us to infer cause effect, even though it's not randomized. And so if you can imagine a population with varying characteristics, and some kids are maintained on anti-seizure medication, some are discontinued. And what propensity scoring does, it's a statistical way of matching equivalent children to see how they turned out. In our study, we matched by quintile, and we powered for non-inferiority. We wanted to make sure it wasn't harmful to stop medicine. So we enrolled more than 300 children, and more than 90% had our primary outcome. And it turns out that 64% were maintained, mostly phenobarb monotherapy, a few on levetiracetam, and then about 20% on polytherapy, also including phenobarbital. So almost all of those were phenobarbital plus levetiracetam. And these are the clinical characteristics. So children that were discontinued were a little more likely to be term, a little more likely to have HIE as the primary cause, more likely to be treated with hypothermia, and more likely to have an abnormal neurologic, less likely to have an abnormal neurologic exam at discharge, a little bit fewer days of seizures on EEG, less likely to be treated with 2 or more anti-seizure medications, and those that were discontinued had a little bit better EEG background. No differences in race, ethnicity, or maternal education. But what we did was took all of these variables to include in the propensity analysis. So to try to examine like with like. And here's what we found. This is that ILAE FS that I told you about, the telephone questionnaire. looking at unadjusted data first. And what you can see is that the results are pretty similar at 12, 18, and 24 months. The kids that were discontinued did just slightly better in the unadjusted. And then when we adjusted for this propensity score, the results are quite similar with the children who were discontinued doing just very slightly better. But the important thing is we found no harm. So we wanted to make sure that there was a non-inferiority, so no more than 12 points lower on the WIDEA, and we well passed that non-inferiority limit. There was also a similar risk of epilepsy. So overall, 13% developed epilepsy before age 2, and this was at a median of 7 months. And that's 11 in the discontinued group and 14% in the maintained group. And here you can see the age at epilepsy onset. Here the hazard ratios are quite similar, so no difference in the age at epilepsy onset. Again, in purple, the maintain, and in gray, the discontinued group. And what you can see is all those children that developed epilepsy at an early onset, so less than 4 months, were in the maintain group. So keeping that medicine didn't prevent them from developing epilepsy. And a third of those had infantile spasms, which we know is a type of epilepsy, a type of seizure that's not going to respond to phenobarbital or to levetiracetam. When we looked at the post-neonatal epilepsy, mostly these were focal epilepsies, which makes sense because they're from early brain injuries, but some with mixed and several that we couldn't figure out. At last follow-up, about a half were seizure-free more than 6 months, but 11% had daily seizures and 24% had treatment-resistant seizures. So these are, important epilepsies. We also found that the risk for abnormal neurodevelopment was much, much higher if you had epilepsy. So 81% in the epilepsy group, 27% in the children without epilepsy. So this wraps up our first section on what's new. So we conclude that it is safe to stop anti-seizure medications after resolution of acute provoked seizures. And the evidence really supports discontinuing anti-seizure medications for most neonates. There's really no clear rationale to continue the anti-seizure medication, so there's no benefit to neurodevelopmental outcome. It prolongs the exposure to potentially harmful medications. It doesn't delay the onset of epilepsy. And in fact, those early onset epilepsies occur in spite of anti-seizure medication maintenance. And a third of that early epilepsy is infantile spasms, which won't respond to phenobarb or Keppra anyway. We were glad to see these consensus guidelines from the International League Against Epilepsy. This is still in preliminary form, but the official recommendation from ILAE is going to be to stop anti-seizure medications in children without evidence of neonatal onset epilepsy, to discontinue before discharge home, regardless of MRI or EEG findings. So recap, is it safe? I asked myself 3 questions before deciding that it's safe. 1, have the seizures stopped for at least 24 hours? So we want to know that the seizures have resolved. 2, were they provoked by an acute injury or a transient cause? So we want to make sure epilepsy was excluded, because epilepsy is a totally different kettle of fish. This is a completely different talk. Today, we're talking about acute provoked seizures. And number 3, have the parents been counseled about what to do if the child has seizures after they go home? It happens. We know that some of these children, many of them develop epilepsy. So we want to equip our parents with some knowledge about what to do in case they see seizures, in which case we'll restart on a seizure medication, but probably not phenobarbital. And if the answer is yes to all 3, then we stop the seizure medicines. People ask me, how do I stop the medicines? Well, here's what I do. I don't check levels, I don't wean meds, and I don't repeat EEGs. This is assuming we're have an acute provoked cause and the child's improving. And that's what I do. I just cold turkey, just stop the medicine. I'm happy to answer questions about that. Okay, we're going to move on to our next section, which is talking about infantile spasms, which we know is a severe early onset epilepsy. I have a few videos to show. Poor little guy loses his pacifier every time he has a spasm. One more. All right, so infantile spasms. So this is a good paper if those of you who haven't read it yet. It's looking at the classification and definition of epilepsy syndromes in neonates and infants. And it's a brand new paper from the International League Against Epilepsy. And it defines these three key categories of epilepsies: self-limited, developmental epileptic encephalopathies, and etiology-specific epilepsies. And here infantile spasms comes under the DEEs. And so the diagnostic criteria, many of you are familiar with this. So seizures that are flexor, extensor, or mixed, and often occurring in clusters. The interictal EEG is classically hypsarrhythmia, but could be multifocal or focal epileptiform discharges. And the age of onset by definition is between 1 and 24 months, mostly onset less than 12 months. So in our neonatal seizure registry, it was quite rare, actually. About 4% of children developed infantile spasms, and that represented about 1/3 of the kids with epilepsy. And it turns out, though, that even though it's rare in our cohort, it's actually quite a common cause of infantile spasms. So these are data from a hospital in China. About half the kids had no etiology, but fully a quarter had an acquired structural cause. So 1/4 of all children with infantile spasms was from something in the newborn period. The other causes were genetic, structural, infections, and inborn errors of metabolism. Now, why is it so important to know who's going to develop infantile spasms? And that's where we're going with this. And the key reason is that the faster we treat, we think the better the children do. These are data from the UCSF study and showing that the children that were treated quickly, less than 1 week, had the best scores on the Vineland, which is a functional developmental assessment, all the way out at age 4. And if we see the longer it took to treat the spasms, the worse the children ended up doing. And so we really want to know for our kids, especially those that had neonatal seizures, that had some acute structural cause, who's going to develop infantile spasms? Can we be alert to monitor and treat sooner rather than later? Because you saw in some of those videos, some of them are quite subtle. We know a lot of pediatricians don't recognize infantile spasms. Often a child is said to have reflux or, some other subtle movement. But really, we want to know how to be alert to catch these spasms. So we looked at risk of infantile spasms in our cohort, and we wanted to know which children are at highest risk so we can keep an eye on them. 7 of our sites participated. We looked at neonatal EEG, MRI, and clinical risk factors. And we did a whole lot of statistics to figure this out, looking at bivariate analyses, best subsets, logistic regression, sensitivity analyses. And then we chose a final model. We really wanted it to balance both the statistical significance with clinical relevance. We wanted it to be kind of obvious for those of us who are working at the bedside to understand these risk factors. And here's what we came up with. 3 key risk factors. One is the EEG, either severely abnormal, so burst suppression or a flat tracing, or 3 or more days of EEG seizures. Number 2, deep gray or brainstem injury on the MRI. And number 3, abnormal tone. And I have a picture of low tone, but it could be low tone or high tone on the discharge exam. And what we found is that children that had no risk factors, none of those kids developed infantile spasms. Children with 1 or 2 of the risk factors, 4%, so the baseline, kind of the average in the whole cohort, developed spasms. But if there were all 3 factors, more than half of those kids developed infantile spasms, so really high risk. So what can we conclude here? Well, we feel that infantile spasms can be predicted based on clinical features. And this is really important for parent education and also for planning follow-up for those of you that are seeing these kids in clinic. So if there's no risk factors, we can reassure. So those of you who see a lot of kids in outpatient, I don't know about you, but I get videos every few weeks. I'm getting a parent with a 4-month-old. My child did this kind of unusual thing. Is it infantile spasms? Because they're all on the internet. If there's no risk factors, of course, we look at the video, we decide if the semiology fits, but if there's no risk factors, that can kind of help us to reassure families. Whereas children with all 3 risk factors, we maybe even want to be proactive with monitoring, counseling the parents about what to look for, having a very low threshold for EEG. And this is the STOP mnemonic from the Child Neurology Foundation. So see the signs, take a video, obtain a diagnosis, and prioritize treatment. And we borrowed those and created this infantile spasms infographic. So this is some work that we did with our parent partners. And this is something that we can give to the parents before they go home to help them look out for infantile spasms and know what to do in case they see spasms. Okay, third section here, looking at time to seizure treatment. This is something we've really tried to dig into and understand. So does it matter when your baby's seizing, you came in the next morning and you realize, uh-oh, they've been seizing all night long on EEG. Is that a big deal? Does it matter? Should we have treated in the middle of the night? And here's some of the data that kind of help us untangle that. These are data from the Irish group. And I should say the Irish group has tons and tons of great data for those of you who are interested in this. This is Geraldine Boylan and her colleagues. And I'm not showing much of their data, but really, if you're interested in this topic, you should be reading her studies. And what they showed is that the faster you treat, so median seizure treatment burden and median seizure burden and median number of seizures are lower with fast treatment, intermediate with intermediate treatment, and higher if it takes a long time to treat. So suggesting that maybe it's a good idea to treat sooner. We tried to get at this with neonatal seizure registry. It was a little harder to do in our data set, but my colleague Courtney Wusthoff looked at screening EEG, so the kids that were encephalopathic but didn't yet have suspected seizures compared to those who had confirmatory EEG. So they had a clinical event suspicious for seizures and found that the treatment success was much better in the screening group. So suggesting maybe that those kids were getting treated earlier and had a better chance of treatment success. Brittany looked at this again. This is a not neonatal seizure registry. This is the HEAL trial, which is a EPO versus placebo for HIE. So a neuroprotection trial, but we took advantage of that trial and looked at the babies with seizures to try to get, again, at this answer, does timing matter? And actually for this group, looking at responders who responded to the first dose of anti-seizure medication versus non-responder didn't actually really make a difference in time to treatment. Also didn't really make much of a difference in total seizure duration. So they very carefully measured, each seizure and how long it was. But what did make the biggest difference was maximum hourly seizure burden. So these children with a high seizure burden per hour, those were the least likely to respond. So with this in mind, I'll just show you a couple of the things that we're thinking about. This is something that we do at UCSF, trying to reduce the time to seizure treatment. And this was a hospital-wide ICU initiative, which is a pharmacy button. So at the bedside, the nurse can press the button as soon as we decide seizures should be treated. The nurse presses a button and the pharmacist can come to the bedside. And this was a QI project by one of our fellows a couple of years ago, looking at seizure treatment response, whether or not the nurse used that seizure button. And she did some quality improvement to increase the use of the seizure button, and found actually the average time to treatment was less than 15 minutes when they used the button, which is our goal. So initiatives, systematic initiatives can help time to treatment. Here's some other work by my colleague Dan Bernardo, looking at our data to see if there's something in the EEG that we can use to predict whether a child will or will not have a seizure in the near future. And so these are just some preliminary data that he's working on. The idea would be to have some sort of alarm or some sort of indication that this child is at very high risk for having seizures in the near future. So similar to automatic seizure detection, but more automatic seizure prediction. So we always, in neurology, we say time is brain, but time is probably also seizing brain, some combination of how long they're seizing and what the seizure burden is. And we know that for many neonates, the longer you're seizing, kind of those seizures ramp up. So it probably makes sense to treat seizures quickly, and particularly before they reach a maximum hourly seizure burden, if you can. But we really, excuse me, need more studies to understand this association between treatment and outcome. Excuse me. Okay, my last section here, I'd like to talk a little bit about parent and family well-being. We know these are key for child development. And the really neat thing about our seizure registry is that we have parent assessment tools to assess parent well-being and open-ended questions at each of our study time points. And this is work that's led by my colleague, Linda Frank, who's in our School of Nursing. And she wanted to understand parent mental health and how the families were doing. And we looked at, excuse me, some validated rating scales to look at rates of anxiety, depression, PTSD. And I should mention, these are not clinical diagnoses. These are rating scales suggesting symptoms of these conditions. And found really high rates: anxiety 50%, depression 30%, PTSD symptoms 25%, and followed those through to 24 months and found that in general, these all got better over time, but many of these symptoms persisted. And this is part of another infographic that we can provide to parents. My colleague, Monica Lemon, has looked at those open-ended questions, trying to figure out what's the parent experience of caring for a neonate with seizures. And she found 4 key themes. First is sources of strength for the families. And when we talk to our parent partners, they really want us to tell the story of the good along with the story of the bad. So things like medical team consensus, everyone being on the same page, opportunities to contribute to care and bonding with the infant, so holding, diaper changes, bathing, all of those typical baby care activities. Sources of uncertainty, just the daily uncertainty of life in the ICU, that long-term uncertainty, what does the child's future hold? And again, this lack of team consensus, people giving different messages, adding to that feeling of uncertainty. Adapting to family life, so trying to understand how will we have to adjust our lifestyle, routines. Is my usual parenting approach that I use for my older child, is this something that I'm going to have to change? And then, of course, financial and work challenges. Am I going to be able to go home and do my same job? Is my relationship with my partner going to be the same or different? And then finally, the emotional and physical toll. So I touched on this in the previous slide, but really themes of anxiety, fear, stress, loss of sleep, helplessness in the face of what's really a very complex early medical course. So here's another infographic that we've made, and these are all available online at our website, really with the message that you're not alone, talking to parents about where they can find resources to help if they're feeling any of these feelings of anxiety or depression. And so our final theme of what's new, really we need to be caring for the parent as well as caring for the child. And how can we do that? Well, first we have to do it because there's really high rates of anxiety and depression. We need to be mindful for these parents and to help support them. The first is like actually not that hard, clear and consistent communication. So making sure as teams we're all communicating together and providing the same message. We do a lot of work with our nurses. All of our bedside nurses that take care of neurobabies are specially trained to do neurologic exam, understand pathology, communication, clinical course, do the cooling. So when we started that program, we did a lot of work with them to say, here's the message we're delivering to the parents today. And when I see a baby, I always tell my nurse, here's the news for the parents. Here's how we're framing things. Here's the language that we're using, and making sure that the neonatology, neurology, nursing teams are all kind of feeding the family with a similar message and similar language, so it's not too confusing for them. So making sure we have consensus within the team. And then encouraging parent participation in bedside care. It's really scary for these families. They see lines, they see tubes. There's a lot of good work now on holding during cooling, for the kids that are more stable. Also, just encouraging the parents to hold the child's hand, to hold the child once they've recovered from that acute phase, doing diaper changes, getting them involved just in the regular bedside care really helps with their bonding. And we have this infographic. This one is for the providers. So best communication practices. And again, our families, our parents helped us to develop these guidelines or these advice. Okay, so if we think back to our case, this was a little baby who had the focal clonic seizures from a stroke. So here's how we approach these kids. So our neurointensive care nursery team, those are our neurology team, co-rounded with the ICN team together at the bedside daily, along with the bedside nurse, again, to help ensure we have that consensus and similar language that we're using and making decisions together. We decided to stop anti-seizure medicines after 48 hours without seizures. And we met with the family together to discuss clinical course imaging findings and plans for follow-up. And then we counseled this family low risk of infantile spasms, so didn't have any of the 3 risk factors. EEG background was normal and just had a few hours of seizures. The MRI did not have basal ganglia or brainstem injury, and the neurologic exam was normal at discharge. So low risk of infantile spasms. I'll just end by acknowledging all of our many, many, many collaborators and our funding sources, and show a beautiful picture of our hospital in UCSF. I'm happy to take questions, but before I do, I just want to remind everyone, for those of you who are not familiar, this is the Newborn Brain Society. It's free for trainees, and there's tons of great educational resources on the website and a weekly seminar. So if you're interested in newborn brain, I really, really encourage you to join. And with that, be happy to take questions from the Zoom audience or from you guys in the crowd. Thank you. Yes. Mm-hmm.
Traditional medication right now also says that and get resistance, saying that it's about the bad medication. what's your opinion?
Yeah, so I guess I would say yes, and it turns out we don't have a good alternative to phenobarb right now. So levetiracetam, I didn't show the data, but from the NeoLev study, it just really doesn't work very well. So from my opinion, the more work we can do to minimize our phenobarb dosing, the better. It actually does work quite well for most babies. So my approach, again, treat sooner, so you aren't going to have to give lots of boluses, but so treating before this baby's in status epilepticus, and then stopping the medicine as soon as you can. And to me, that minimizing approach, it's kind of the best we can do right now because we don't have other options. So we use phenobarb first line, and that's this ILAE, the rough draft of the guidelines have phenobarb as first line. And we use fosphenytoin as second line. Fosphenytoin works really well. It's a terrible drug for babies. Like, you can't keep levels. It's like hard to use, but to use it for 2 days in a baby who needed a second med, it's great. So those, for most of our babies, we're using just those 2 drugs. Yes.
High risk for infantile spasms. Is there any role for serial EEGs for the first few months or the TS patients?
Yeah, so that's a great question. I think that's kind of where we're leading with our research. I don't think the data are there yet. We did, so part of the data that I didn't show, we did 3-month EEGs for all the kids, because that's kind of like, that's again, the kind of old school standard of you keep them on medicine and you do the 3-month EEG and you make decisions from there. It turned out that EEG really wasn't very helpful for determining who is at high risk for epilepsy. But we did catch a few kids that had hypsarrhythmia on that EEG. So I guess the answer is probably, but we don't have the data there. I think a trial like EpiStop for tuberous sclerosis. So for those of you who don't know, there's a few trials now doing serial EEG and kind of anticipatory treatment for children at very high risk for infantile spasms, like children with tuberous sclerosis, showing a benefit of monitoring and treatment. That's kind of the idea of what we would like to do and show moving forward. First, we have to validate the risk factors, and then get a big enough group of babies that are high risk, which will be even bigger multi-center studies. Oh, sorry, I can't see. I didn't see you over there. It's a huge screen, and it's like in the opposite direction from this screen. So I wasn't sure, and I'm so short, so it's hard to see over the thing. Yeah.
Just a couple oppositional points about phenobarb.
Yeah.
I think you should stop it early and stop it abruptly. It doesn't make any difference. All studies show that the level is what's important. Maybe one step back in the but on the good side of phenobarbital is in your study where you stopped and follow other patients continue on medication. Well, if you don't measure levels on the patients who are on phenobarbital, it's not really a real comparable group. And I'm sure you did measure levels, because no one's going to. Is that correct?
We
continue on medication.
It was all clinical care. We did not collect those data. Yeah.
But it's not really, if you know what the level of phenobarbital is, like level's 10, it's not working. And most of those patients do outgrow it unless they were increased. So I'm not sure that's really comparable, although it doesn't take anything away from your conclusion. You should stop it, and that doesn't change anything. The other point that you made, which I'm not sure is right or wrong, but the phenobarbital does not protect from spasms. Well, I was taught by really old people that phenobarbital works at 30% of infantile spasms. I'm not sure where that data came from. I have seen it clinically. I've stopped. I have patients that I use phenobarbital to stop the infantile spasms one time. So
okay.
That's really anecdotal. But I was taught that it worked 30% of the time.
Okay. Yeah, I'm not familiar with those data. I know it's not the recommended treatment currently for infantile spasms, but yeah, it could work. Could work sometimes. Yeah. Great. Thank you. Good point.
It may not be so bad. That's the only thing.
It may not be so bad. We really got to find something better. We hope to find something better. Great. Other questions? Yeah. Yeah, so it wasn't statistically significant as one thing, but the other thing is, so those kids that were continued on medicine, so this was clinical practice. It wasn't randomized. The doctor just decided yes or no, do I need to continue medicine? So the kids that were sicker, that would be higher risk anyway, tended to be continued on medicine anyway. So that's part of why we couldn't just compare them head to head, because they're different groups. That's why we had to use the propensity score to kind of make them equivalent to compare them, if that makes sense. Also, the important point here is that we weren't powered to detect differences in epilepsy. You would need a much larger group to study that question. And I should say, so hopefully, I think there's funding now to do some learning health systems. So from one of your colleagues up at Cornell, Zach Greenspan, I don't know if any of you know him, but he is, I think, funded to start using the electronic medical record to do some of this work. So looking at discontinuation of anti-seizure medicines, looking at the type of seizure medicines that were given, and looking at risk of infantile spasms in a much bigger cohort, and with some work using the electronic medical record to avoid some of this painstakingly detailed work that we had to do with chart reviews, et cetera. Yeah. Yeah, so it's a good question. I'm not an epileptologist, so I should not speak for my colleagues. I think we follow standard, steroids or vigabatrin or dual therapy. I think some of our attendings like to start with dual therapy, but I honestly I'm not positive, because I send those kids to epilepsy doctors when I see them. Oh, a question in the chat. Yep. Let's see. Okay, great. Thank you. Question in the chat. Would neonatal seizures caused by metabolic conditions like MCAD, B6 deficiency, and others require longer treatment after seizure stop? So that's a great question. It's a very broad question. I think that once you're talking about epilepsy, so either a genetic epilepsy like KCNQ2, brain malformation, an inborn error of metabolism, all bets are off. Now we're talking about precision therapy. We're talking about a precision treatment for a specific diagnosis. So it would depend on what the condition was and what the best treatment is, but we're no longer using these blanket suggestions like using phenobarb and stopping meds. Now we're thinking very carefully about what is the condition, what is the treatment, and how long is the treatment duration. Good question. Thank you. Yeah. Yeah, so the question's about neuroprotection. We don't have anything right now, unfortunately. So that HEAL trial, I did not show much data from that, but that wasn't helpful. That was erythropoietin. Didn't do anything at all. My colleague, Adam Numis, is looking a lot at inflammation, studying biomarkers. Is there some type of anti-inflammatory that could be given to help prevent later onset of epilepsy? I think that's his hypothesis to study. There's lots of really interesting work to be done, lots of things to study. So I encourage anyone in the audience who wants to do research in this area. There's a lot of open questions. I think that was the question oh, maybe one more, okay. Any news about ganaloxone versus phenobarbital? So I feel like I saw something recently, but I can't remember if that was an abstract or a paper or a preprint. So ganaloxone is like a hormone that's derived from the placenta, I believe. Your colleague Anna Penn up at Columbia is doing a lot of work on placenta and baby brain. I don't know the answer to that. I know there's some work out there, but I'd have to look that up to give you a smart answer. Okay, great. Thank you guys.